TopMedTalk.
Hello and welcome back for our second to last session of EBPOM Chicago and our EBPOM Ireland meeting. Personalized versus protocolized perioperative pain prediction and pain management. I'm Desiree Chappell, managing editor of TopMedTalk, a co-chair for this meeting. I'm also a CRNA in the States and vice president of clinical quality for NorthStar Anesthesia. I'm joined here in Dingle, Ireland by one of our co-chairs, Monty Mythen. Hello, Monty. How are you?
Great to be back.
And then we're joined by Saul Aronson, co-chairing this session as well in the United States. Saul, it's so wonderful to see you again.
Good to see you guys again. Fun topic, very hot topic that we're about to engage in.
Yeah, absolutely. Pain management in the perioperative space. I'm going to go with each one and have them give a little bit more about their background. But we have David Edwards. He's an anesthesiologist and the chief of the division of pain medicine at Vanderbilt, just a little bit south of Kentucky. David, it's wonderful to see you. Thank you so much for joining us.
Sure. I'm originally from Canada and did all my training down here in the United States. So I know nothing of socialized medicine. I'm a pain management provider, but my true love is acute pain. But, to do all and to try to get a good experience in the continuum of care, I did a chronic pain fellowship in Boston, but landed here finally, ultimately at Vanderbilt, training and teaching other pain management providers and overseeing systems that try to bring and optimize care to the patients here. So good to be part of this with everyone.
Well, Geeta Nagpal, you are an anesthesiologist at Northwestern, so you technically are holding it down for us in Chicago. Thank you so much for joining us.
Thank you for having me. Yes, I'm an anesthesiologist, but I mostly practice chronic pain medicine. So while I grace the ORs with my presence every once in a while, my home really is in the Northwestern Chronic Pain Center, where I treat subacute and chronic pain, usually by interventional methods. We do some medication management, and I help other providers with opioid weans pre and post-operatively as well.
And then representing this side of the pond, and this side I mean Ireland and England, is Nicholas Levy, who is a consultant in anesthesia and acute pain medicine in Suffolk. Nicholas, thank you so much for joining us.
Yes, good evening, good afternoon. My name is Nicholas Levy. I'm a consultant at a small district general hospital in Suffolk, which is in East Anglia. My main interest has been in perioperative medicine and improving the recovery of patients. And along that journey, realizing that the opioids that we've used are causing harm, and actually utilizing unidimensional pain scores to guide further interventions, especially opioid, is wrong and leads to harm. And so that's really been my journey.
Nicholas, if I could intervene for a moment. Without knowing, you're one of Desiree's poster children. I don't know if children's the right word, but because she's been seduced by the concept of dreaming, drink, eat, mobilize. And I was lucky enough to co-author with you an editorial back in 2015, 2016, stimulated by discussions about functional pain management in the sort of peak of enhanced recovery in the UK. And you came up with this very clever editorial to say, in pursuit of dreaming, the ultimate goal of anesthesia, which I think is a lot of what we're going to talk about in the acute setting. In other words, it's important to tell patients it's going to hurt and manage their expectations.
For me, I realized over a period of time is that actually the idea of surgery and anesthesia and pain relief is to promote recovery. And actually, it's the restoration of function that is vital. And therefore, dreaming, drinking, eating, mobilizing is a key component of promoting recovery. And it also led to the recognition, as we've heard, that we need to avoid tethering the patient to the bed space, which means getting rid of PCAs and epidurals and utilizing the oral route when it is possible. But at the same time as utilizing the oral route and using opioids, at the same time, realize that the unfettered use of opioids cause problems. And so we need to promote deprescribing post-operatively as well. There is a time and place for opioids, but there's also a very important time for deprescribing. And the dreaming and deprescribing go hand in hand.
Saul, did you want to make a comment or a question?
I do, and I did. And I put it to all of you smart people out there, and I don't claim to be one of you. A theme that we saw in our last session, for those of you who watch it, in the smoking cessation program, was that facts matter. It's important to know that smoking's bad for you, and I don't think anybody would dispute that. Nonetheless, we need to approach patients very much in a personalized manner, and that not one size fits all. And people have issues that relate to them smoking and not being able to quit. Now, with that theme there, I'm going to ask this question in this context. Pain, I think thematically, is the same sort of story. We're now approaching that place in space and time where we appreciate that opioids are bad, and that, for a decade, we were sort of blindly going down a primrose path and doing things not necessarily well or on the best behalf of our patients. And there's a plethora of facts right now that we all appreciate with respect to the harmful effects of opioids. That said, how do we best approach the patient with chronic pain through the lens of personalizing the treatment and not just having a blanket statement that we should avoid opioids and get on with it because that will fix the problems that we created? And I know that's complex, and I'm going to ask Geeta and then Nicholas and then David to sort of speak to that as a tipping off point for this discussion.
Yeah, I think that's a good commentary and question. And I think one thing we can take out of that, or I take out of it, is we all agree that opioids are bad. But I don't like to talk to patients with that language, because while tobacco, people are using it more as a fun thing to do, and it becomes addictive, it's not prescribed. A lot of the patients that I'm dealing with are using their opioids in a prescribed manner by their doctor. They're not addicted, and I don't want to have them come to me, and I don't want to tell them they're doing something bad or wrong. So I kind of talk about it more in the sense of opioids can be really great in certain circumstances. If you break your ankle and you need a dose or two in the first few days of an injury, they work really well. But when they don't work well, and we know this, and I know it personally now from a decade of experience, is when we have you on high doses and for a prolonged amount of time. And so I really try to talk tolerance and dependence. And what I find a lot of patients hear from tolerance and dependence, and I've had 2 patients just yesterday ask me the same question with the conversation. Are you saying I'm a junkie? No, I'm not saying you're a junkie, but that's what people hear. And so tolerance and dependence, people need to be educated about that more, and that it is completely separate from addiction while it can lead to addiction. I talk about that in opioid-induced hyperalgesia, et cetera, so that they can kind of understand why we are where we are. You may be seeing more patients in the operating room. I'm seeing patients that are now post-fusion 5 years later coming to me, and they're on 70, 100 morphine milligram equivalents per day and wondering why they're still in pain. And so we can discuss those things and talk about how we can make that change and how difficult really it is going to be, because I then do relate it to smoking or overeating, obesity, where it's very easy for us to say, we need to hold this, you need to quit, you need to come off. But it's much harder for a patient to do than it is for us to say. I think it's also hard for a lot of practitioners to do. It takes a lot of one-on-one time. It takes a lot of re-prescribing. I use an analogy to crisps or potato chips. I'm a savory kind of girl. So if you put a little bowl of chips in front of me, or a little like fun-sized kid bag, sure, I'll eat like a dedicated amount. But if you give me a party-sized bag, I'm probably going to eat a lot more. So when we talk about opioid weans also, it's maybe not going to be the same prescriptions that you're used to. Maybe we need to do week prescriptions instead of one month prescriptions, because we have to make it something tangible for a person who is going to probably have a lot of cravings, even though it's not necessarily addiction. So I know I kind of went a lot of directions with that, but I think that when we tell patients they're doing something bad, they may not want to listen to us anymore. So I've tried to turn it into, you're doing what you've been prescribed, but we need to pivot and change this treatment pathway.
Nicholas?
Really concur with some of those points. The angle that I would like to examine is that when we prescribe opioids, we need to treat them like we do with antibiotics and think about it as a course with a definite end date. And that's something that is being pushed by the regulatory body now in the UK, is the need to think about a definite end date and think about it as a course. Totally agree that there is a time and place for opioids, and also totally agree that the unfettered use is associated with harm. And we need to be able to help patients, firstly, not be persistent users, but once they are persistent users, wean them off.
I want to get back to the wean them off point, but I'm going to ask David to speak to that.
I appreciate both of your comments. It brings up a lot of thoughts for me. I have patients in my clinic, in chronic pain clinic, who are on opioids and who are preparing for surgery. And I see the fear in their eyes, and they're coming with an extra comorbidity. You know, a lot of patients are scared of surgery and the pain that will be involved, but people with chronic pain who are on substances maybe have a higher level of anxiety, maybe some depression that goes along with it, and we can stratify that. I think the benefit of protocolizing our pathways is that we keep a lot of things systematic so that we can discover the variability in the outcomes of particular patients when we stratify. And so that's where the personalization comes in. And I love it when I see a patient in my clinic and they're headed for spine surgery, and I also do anesthesia. So I get to oftentimes go in and do the anesthesia for my patient. And then I get to see them in the clinic afterwards. And we've set up this whole continuum of care. And I think as we learn to connect those dots between our services, not just our personal dots, it almost becomes like a picture in my mind, like a travel agency and a travel agent guiding someone through back to where they were before. I think they love it. I think we all know that they love it when they have a good experience and they were so afraid. But we did something there and we intervened in a way that we can really make a difference. And I 100% agree with you. We can actually do that without opioids oftentimes, and even the patients with chronic pain. So,
absolutely.
Great answers. What I learned, thank you. Wonderful discussion. I fear I might be addicted to potato chips, but we'll get to that later. What role is catastrophizing as a personality trait affecting, if you will, this discussion? How do we tease that out? How do we manage it when we find it?
Sure. I think that comes out and we can measure it with the scales, of course. And sometimes we do that. I hate the word, by the way, catastrophizing, and I never even bring it up to my patients, but I do check off the list in my mind. Yeah, well, over anxious, I don't know. That's bad too.
Okay.
You're right. We need a word to replace that, probably. But we all know what it means. We ask those questions. What are you most worried about? Do you feel like you are in control? Do you feel like we have a plan? And most patients will say, yeah, I think that's a good plan. I trust it. Let's go forward. And those with catastrophizing type behaviors will say, well, I'm worried that it's not going to work. And what if it doesn't work? And what if that doesn't work? And you'll go down plan B and C and D, and they'll still say, well, what if that doesn't work? And that definitely is a hand-holding experience all the way through to the end and back down the other side. And it's definitely a challenge. I'm interested in what others have to say about that.
Nicholas?
Yes, totally agree that looking after people with catastrophizing personalities is a struggle. But this is where I think, as we heard from Dr. Gummer earlier, the building in appropriate expectations and shared decision makings can go to alleviate some of these issues. And it really is about building in appropriate expectations. No one's done the studies yet that pain catastrophizers, that building in expectations improves the outcomes, but there is beginning to be exciting work that psychological preparation does improve clinical outcomes. And there's no reason why these folk who are labeled pain catastrophizers will not get benefit from that as well.
Geeta?
Yeah, the responses thus far have been great with people that are over anxious, et cetera. I see that a lot in my clinic. Again, I'm seeing patients that have maybe gone from one surgeon, one city, all over the place. We have people that have had 5 fusion revisions. And so there is a lot of realness to that. They have been through so much. Somehow our medical system allows people to be fused over and over and over again. And so I have to be able to manage it. And I think it is setting expectations. I have a lot of little silly things that I talk about. I talk about magic fairy wands, which I wish I had, but I am unable to cure everyone, and talking about pain as a similarity to something like diabetes or asthma, where we have ways of controlling these chronic illnesses, but not necessarily curing them. So it's just more about taking time with these patients. I enjoy some patients that are maybe a little bit more anxious because to me, it makes me feel like it's more real. I have a lot of people that come in and just say, okay, let's have an injection. And I'm like, oh, you really aren't worried at all. But then we have the other side too. And so I think managing expectations is one of the biggest things we have to do in pain management, and is probably going to help with our opioid epidemic as well. Because if we can say it's okay to hurt, you're not dying if you hurt. It's okay to feel that way. It doesn't mean you injured yourself. It's okay that you feel that. It doesn't mean that the epidural or the surgery didn't work. These are the expectations we have. You're not going to be floating on cupcakes and rainbows after this. There's going to be some work. And we all need to be on a team to do that. We need our anesthesiologists, the surgeons, the nurses, everyone, not trying to scare people, but to just set those valuable expectations so people aren't worried about what is to come.
Geeta, you mentioned there the sort of acceptance of the fact that it's going to hurt, which very much at one stage triggered this transition from the pain score, waking people up who are sleeping in the middle of the night to ask them if it hurts, and now it does. And if you record bad pain scores, the next minute you're in trouble because your institution doesn't care enough about pain. So I think there was a time in which we created, to a certain extent, this problem of saying the fact that we must eliminate all pain. And the go-to thing was the opioid. Do you think we've moved away from that now? We can still say that we have patients who are satisfied because their pain is okay and they're prioritizing their ability to mobilize and get home as opposed to have a zero pain score.
I think we're getting there. I don't think that we've completely gotten there. Otherwise, we wouldn't still be in the situation we are with opioids. So I think that there are a lot of people that go into surgery expecting I am having a surgery. It is a traumatic thing happening to my body, so I should expect that I'm not going to feel like I want to go travel or something right afterwards. But I think there's still a number of people, and all of these things take time. And I think that also I live in a little bubble, and a lot of you guys with where you are live in bubbles, and medical bubbles, where we might have different resources, time, and people to help build those expectations and protocolization, but we still see patients coming from other places that might not have that, or have primary care doctors that haven't shifted and pivoted with the times, that are still prescribing opioids and benzodiazepines and things like that. And so we're not 100% there, but I think we're moving in that direction. I certainly started pain medicine. I'm a decade into this job. I started in the time where there was the wake-up call of opioids. So when I was training in Boston, we really weren't using them. The CDC was 5 years later after I graduated, with their guidelines for primary care providers. But I think all of this does take time, because we're not dealing with just teaching medical students and then moving on and changing everything. We have to change all of our behaviors, and people that have trained 20 and 30 years ago as well.
Just to follow that up a little bit, patient satisfaction scores in all of our healthcare systems are quite rightly very highly valued. But at one stage, we certainly in the United Kingdom had this heavy weighting on nobody having pain. Has that stopped?
I think that we have moved away from that a lot. We still have it. When we look and we use our Epic, and you can still see that pain scores are written there. But even when I take acute pain call, we're not getting paged when someone is a 7 or an 8. It is more kind of for our information, and it's more based on the patient experience and how they look to the nurses or the team, how they're functioning, which is more important than the actual number that's being written down. And that number is such an individual number. My number is different than your number. I, as a pain doctor, went in labor with my second kid, and they asked me what my pain score was. And I said it was a 2. And then they left me alone. And I was like, oh my God, I need help. And so they asked the pain doctor the wrong question, right? So we really have to look at how a patient is acting, functioning, able to eat, able to participate in physical therapy, which is going to be much more important than a number.
Yes, completely agree that we should no longer be chasing the unidimensional pain scores. And the first hint of that being brought into the public domain, I think, was in the JC Joint Commission publication of about 2017, when it said that actually we should be promoting analgesia to promote function. So on the day of surgery, day after, if they've had major cavity surgery, we should be promoting coughing and then subsequently promoting mobilization, which comes back to dreaming. But I think the Australians have taken it to the next level. They call it the functional activity score. And actually, rather than titrating opioids to the unidimensional pain score, they're titrating opioids to promote restoration of function. And it does seem to be in the hospitals that are using it very successful in improving patient satisfaction. And there's been a couple of studies that have been published that shows that. But obviously, it hasn't gained widespread attention. It's not validated. But then again, the unidimensional pain score, despite what people think, is not validated for pain interventions.
David?
I like how it's all moved, and I experienced the same things that both of you experienced, I think, in the last little bit, where the hospitals and nurses and staff are focusing less on the score that you see go across your screen and throwing an opioid at it to see if you can go down and make your satisfaction go up, which never works. And now we're actually asking the follow-up question, your pain is an 8 out of 10? Oh, okay. Is that acceptable to you? Yeah, actually, I'm fine. That's my pain score at home, so I feel pretty good. Okay, so you don't need an opioid? No, of course you don't. And that's been measured, right? Like, patients, they're done with their prescription long before they're done using the prescription long before it runs out. So we are always prescribing way too much, giving way too much, and the patients don't need it. So I think we're moving in the right direction. We're just listening to them and seeing how they're functioning.
Yeah. Right, Desiree.
No, I think it's been great to have those conversations with the providers, for them to understand that. I do want to talk about some of the protocols. And David, you had mentioned this, and, your work through the continuum, I think, is very, very important. And I loved the idea that you would actually have a non-surgeon following the pain piece as the acute on chronic, on, back to chronic, however you want to look at it, you know what I mean? That we have somebody follow that, because I feel like those people get dropped out. But when it comes to protocols, that means different things to different people in different institutions. You could have a pain escalation protocol for postoperatively, but you don't really have anything preoperatively, or you could have some pre-op risk stratification, but that doesn't really translate postoperatively. Tell me a little bit about your experience there. And I'd like to go around the panel too, just to hear more about it. David.
Sure. I think that in my mind, as I've been going through my training and doing reading and interacting with colleagues like you all, you come across the same vision. We just say it in different ways. Hans Clark, 10, 12 years ago, reformulated, maybe rebranded this process in transitional pain management, TPS. And those kind of systems are popping up. It's just an organized fashion of taking patients through that continuum of care, whether it's one person like me going and following them through, or really well-connected systems and teams that communicate well together on behalf of the patient. And when provider A upstream knows what provider B is going to do in their enhanced recovery system, it can set the expectation for a patient that this is what are the options are for you. But because you are you, this is how we're going to modify that program. And we're going to start you on this, this, and this, and recommend that you have this regional anesthetic. And we know that my acute pain specialist downtown and my surgeon are going to take it up the next level, add the next dose, incorporate the regional anesthetic. And I can kind of predict they're going to go up 25%. You're going to see me in 2 weeks after that surgery, because I know that you probably won't see your surgeon for 6 weeks. So we're going to check on you halfway there, and God willing, you'll be even off of those opioids by the time you go back and see your surgeon, and it's probably likely, and I'm here to help you. So, setting up a system like that where everyone's familiar with the pathways, with all the evidence-based options tailored specific to that patient, I think they really get buy-in from that and good outcomes.
Nicholas, how about you?
Totally agree that actually there are things along the patient pathway that should be done and should be protocolized to ensure that they happen. But then the response has to be individualized to the individual patient. So for me, taking tangible examples, preoperatively, there should be discussions to ensure that there are realistic expectations about the course of recovery. That should be a standard of care. Certain things should happen interoperatively. And I think the prospect group, the procedure Pacific group, are working to elude the best forms of interoperative management. And then post-operatively, there are certain things that we should be doing. We should be ensuring that people are given humanitarian pain relief and that their function is promoted. But how we do that needs to be individualized. And likewise, people should be discharged with appropriate analgesia that is appropriate for their needs. But they will need some take-home medicines, but it needs to be individualized. It's trying to combine the two phrases, protocolize and individualize.
Geeta, from your perspective, I'd love to hear if someone is on a protocol, when that all starts for you, being a little bit further removed in the chronic space.
It's not funny, but interesting that we are getting there, but I feel like it's not quite like this.
Right.
How's that?
Yeah.
So I can give an example from yesterday. I had a patient re-referred for epidural steroid injection because she was told she was not a candidate for the fusion, laminectomy infusion that she actually probably needs because she's incredibly stenosed and has terrible neurogenic claudication. And I said, oh, was it because of your size or whatever? Because there's a lot of different protocols of cutoffs of everything. And she said, no, it's because I'm on hydrocodone. And I said, okay, did the surgeon tell you what the goals are? And she said, no, they just said that I'm not a candidate. And so then I reviewed at the note and I was like, oh, I don't actually know what the goals are. So I had to reach out to the surgeon. And so we all kind of have to be on the same page. If the goal is to be on zero opioid prior to surgery, okay, but I need to know, the patient needs to know, is every patient supposed to have the exact same protocol? Because I don't know that either. And we have to kind of be able to pivot and maneuver with that. But I think we're on that page of understanding that we don't want patients going into surgery on high dose opioids. I think we know that there's just so many risks, more ER visits, potentially wound dehiscence, longer hospitalizations, et cetera. But we also have to be able to communicate that to the patient and come up with a good plan. And I would say currently where my space is, I feel very disconnected. I feel that in the same way as with the obesity epidemic, where people will refer to me and say, oh, I'm not a candidate for surgery because I carry too much weight. And I was like, what goal were you given? Oh, I wasn't given a goal. I'm like, oh no, how are we supposed to work with anything if we don't have a goal? So I think that we may be on a different page here, or maybe me, myself, am not in the loop. But I think that when we have protocols, we need the whole team on it. And then we have to consider every patient individually, as you guys mentioned, because not everyone's going to be able to fit a specific thing.
So to that point, and again, I'm drawing from, analogies and other things that we've talked about during this session. What I'm thinking now is the program we just had this morning on preoperative diabetes and our preoperative diabetes clinic to control patients who had poor glucose control. And one of the themes that came up in that discussion was obviously, we know the facts, and people with poor glucose tolerance and poor glucose control do less well than people who have good glucose control. And, non-diabetics do better than diabetics, and poorly controlled diabetics do less well than well-controlled diabetics, and all that sort of stuff. And we know that. And so we have triggers, and, we happen to have a trigger in our Duke clinic that an A1C of greater than 7.5 was sort of an indicator of somebody who had poorly controlled diabetes or glucose, and that patient should be sent on forward to have their sugar tolerance better evaluated and coached and managed and all those sort of stuff. And that's a good thing if we can accomplish that. And indeed, there are some patients who come to surgery and are evaluated and they have hemoglobin A1Cs of 12 or 13 or 14, and they're terribly bad managed. When we send, sorry for the long-winded introduction, but that patient, sometimes we send to the clinic for their diabetic management. And after a week or 2 or 4, the endocrinologist will call us back and say, look, we're never going to get this patient down below 7.5. They're 8.5. And frankly, that's as good as they're ever going to be. Take it or leave it, but that's optimized. So with that said, what is that cutoff? What is that threshold for the chronic opioid, if you will, trigger the patient, who is a chronic pain syndrome, who's taking massive doses of opioids, because we know opioids unto themselves are bad for you. What should our trigger be? And is there such a thing as a tolerance?
Sure. In regards to opioids, in comparison to setting a number, like we might be able to set a number with glucose control. We had that same question, maybe it's been 5 years ago, in the Perioperative Quality Initiative meeting here in Nashville. And we published a paper on the perioperative management of patients on opioids. And we decided as a group that we needed to answer that question and figure out, is there a number and is there a range that puts a person at risk? And so we created a scoring system called the Opioid Naive, Exposed, and Tolerant Plus score, the ONET Plus score. And so the first step is to classify or categorize a patient if they're naive, not on anything, if they're exposed on any level of opioid within the last 6 months, or if they are tolerant by NIH definitions or CDC definitions of 60 morphine equivalents 7 days leading up to the time of surgery. And just by categorizing someone there, we don't know if there are risks of those different categories, but we need to find that answer. And, we operationalized that score here at Vanderbilt into our transitional pain service, where we classify patients into those categories with the goal of optimizing the plus part, which is the comorbidities, the anxiety, depression, and major surgeries and painful surgeries, to create a plan that's targeted for the next lower risk class. So if they come in and they're a high risk by the ONET score, our goal is to say, hey, we think they're high risk. Let's follow and see if they have poor outcomes compared to the other classifications. But let's also use that scoring system to say, let's create a plan where they're high risk now, but if they follow our plan, they're going to be a moderate risk by our score. Sorry to say we don't have outcome measures to give you, but I think the question is very valid, and we've been doing that now for about 3 years, and hopefully to report that soon. But I think others have done similar things with a similar question. What's the score? Is there a cutoff? I don't know, and I appreciate hearing from others.
So your turn, Nicholas.
Yeah, recently with Dilip Lobo, a surgeon from Nottingham that works closely with Enhanced Recovery, we did a narrative review that was published in the BJA. All we can really identify that previous opioid use prior to surgery, as well as leading to worse pain outcomes, is also associated with other worse outcomes, whether increased risk of systemic infection, localized infection, due to the immunomodulatory effects of opioids. And it was very difficult to tease out the dose. It was difficult to tease out whether some opioids are worse than others because of their immunomodulatory effect. So it's very difficult, but all we can really say is that opioids are associated with a worse outcome. So I think we're left going back to shared decision-making and going back to the patient and saying, when we operate with you on opioids, you are at increased risk of these sort of issues. And once the team is happy, and I include the patient in the team, that's the time to go for the surgery. But they need to be aware that the surgery itself may have a worse outcome. And there is nothing worse than trying to do, for example, a joint replacement, which is meant to increase their function and enjoyment of life, and then them getting a deep infection, and that being a disaster for everyone concerned.
Geeta, is that the sort of logic that you would bring to that patient in the scenario you just described in terms of setting expectations?
Yes. And I do discuss with them, that there's been, I probably need to read more updated things, but a lot of retrospective studies, and with knee replacement, cervical anterior fusions, as well as abdominal surgeries, that have shown that the people that are on opioids and, the more chronic opioid use going into their surgery have all of what was just discussed with those longer hospital stays. I think infection and redo surgery are probably the scariest for me. And I do bring that up to a patient. Could you imagine you're going in to have your neck done? You are on a medication because you have fire going down your arm. So you're on this opioid because you're trying to treat it, but you need to have surgery to treat it. But you end up being at higher risk for ending up in the emergency room, having a wound problem, potentially even getting a redo surgery because you're on opioids. This is how I tell them this is important, that we need to figure out how to dose reduce. Now, there was a study, and I actually presented it like a few years ago when we were in person for this lovely conference. And it was comparing a control opioid and then some dose reduced opioid patients. So 3 different groups for knee replacement. And the people that even just dose reduced their opioids had much better function. So they weren't completely off, but they had better function than compared to the opioid kind of maintenance group. So, I think that it's how I discuss weight also with my patients is be proud of like every pound you can get off. We need to take every MME that we can get off and use that as this is advantageous. Being on 30 MME is likely going to be better for you than 50 MME going into this surgery. But if someone can't even function and be able to like brush their teeth because they're in so much pain, we have to weigh that as well. So that's sort of how I go about it with my patients. Again, not having the full connect because I'm not then going into the operating room with them or necessarily seeing them afterwards. But I take this upon as my own interest and my own care for my patients, that when I see someone who I know is headed in that direction, that I want to help them with that.
Geeta, if I could come back on that, because I remember the discussions, as privileged to be part of the discussions we're talking about, is a pragmatic takeaway seemed to me that what we're aiming for here is dose reduction, which eliminates the sort of variability of your starting dose, the pharmacogenomics of it, the chronicity of it. So sure, we'd love, if possible, to get your dose down by 50%. That would be wonderful. But why don't we start by trying to get it down by 10%? Because anything seemed to be a gain. And I think you could make sense of that biologically and pharmacologically, that any reduction should be a win. That, to me, as a non-specialist, very rarely involved in this space, that seemed like a very pragmatic recommendation.
I think that's reasonable, achievable. And then, it just depends on the timeline too. Some patients can wait. Like these aren't urgent, emergent surgeries. And if you can wait, then 10% isn't good enough. Let's wait and do this. But if, you have neurologic compromise or something, you may not have that time. But if you're on the schedule for next week, let's do our best to get as much as we can down before you go into surgery. So that's where we have to weigh each patient differently. But I think dose reduction is certainly better than nothing.
You shared a scenario, Geeta, about a surgeon who didn't want to do surgery because the patient was on oxy. When do you tell the surgeon who wants to do surgery not to do surgery because you can still do better?
If I have that relationship with the patient, I certainly will. And I don't tell the surgeon necessarily what to do. I have more of the patient because I have that relationship. If it's the surgeons I'm working for, we typically are on the same page and I know them very well. But I think that I have more influence on a patient than I do on a surgeon that I may not work with that much. Because I get referrals from all over. People aren't necessarily only getting their surgeries done at Northwestern. So where is my impact going to be the greatest? Calling up someone cold and saying, hey, we need to get this down, maybe. But I think also my patients do trust me and respect my judgment of their care. And so I use a lot of that on them and saying, should we consider this? Do you need to have this right now? Can we do better?
Nicholas, I know you raised your hand earlier too, so you may have a comment about a previous topic.
Yes, it was really bringing back Geeta's point that was raised by Monty. Is any dose reduction useful? What I just really wanted to highlight is on the back of COVID. One of my big fears, especially in the UK where we're seeing the waiting lists go up, is while people are waiting for surgery, they're going to be commenced on opioids. And then because of that, their outcomes are going to be worse. And I think that's going to be a challenge for us all, whether we're in primary, secondary or tertiary care. So that was the point. But I just thought it was quite an important comment to follow Geeta's point that opioid dose reduction is vital. But really with COVID, we're going to see the opposite.
I totally agree. And, I was practicing, I feel like poorly because we thought COVID was going to be a couple weeks, remember? Does anyone remember that? Where we thought we were just going to shut down for a few weeks. And so we were shut down like in the clinic and now we're only doing telehealth calls. I don't have the usual means I have. And so we all as a group noticed, oh my gosh, I'm being a little bit more, I don't really prescribe very many opioids. And suddenly now I'm like, okay, well, let's get you a little tramadol until the clinic opens again or this. And then I'm like, oh, this is going on a little bit longer than I expected. We need to pump the brakes on this because I don't want this to be what the expectation is or turn it into something chronic. And so here we are, however many months, 19, 20 months later. And so if people didn't, I still have patients that are like, oh, I don't want to come in. I only want to do telehealth. I'm like, well, we're not there anymore. We have to be able to talk about things, examine you, and do other options. But if we don't capture that, then certainly we can fall down that slippery slope.
And David, any comments on this?
Yeah, I think your pointed question of what do you tell surgeons? Can you tell them to wait? And I'm just thinking of, the 5 or 6 surgeons that I interact with, that we interact with, they're very good communicators. They want the best outcomes too. Mm. And, a few years ago, Kristen Archer published in Spine her article where the higher dose of opioids you are coming in, the more likely you are to be escalated, but to stay escalated longer. Mm-hmm. And so with that knowledge, we're just doing harm if we don't have a plan by taking a patient on high dose opioids through a major surgery, escalating them, putting them at longer risk, and reducing their long-term functional outcomes. And so, I really appreciate our surgeons who, we have some who will say, I don't operate on people with opioids, or I want you to go and see Dr. Edwards or his team to get down first. But they will take my opinion. We tried for a long time. This is about like the glucose thing. This is as good as we can get. They're in so much pain and poor function. We really think we can get the rest of the way if you do this minor surgery. But also on the flip side, I have complex spine surgeons who will say, everyone look at this patient 3 or 4 weeks ahead of time by email. And I think they're really at high risk. Does everyone agree to proceed with this patient? And they take all of our input. And I appreciate having partners like that because we're all looking out for the best outcomes of each other and the patient.
Last question as we wrap up here. We've talked a lot about kind of the chronic pain space and everything we do in the perioperative continuum. One of the things that you hear a lot when we're talking about personalized versus protocolized, whatever pain management that we're doing for our surgical, our perioperative patient, is around opioid-free and opioid-sparing analgesia for opioid-naive and chronic pain patients. So just kind of wanted to get some perspective there and see if that really fits into, protocols that you're using or, what you're thinking there. David, I'm going to start with you on this one.
Sure. I want to throw a curveball into this answer and just give a really specific example. I also practice in what's called a bridge clinic for patients who have overdosed and are trying to recover, and they're high risk and they undergo surgery and such. But what I've learned from that scenario is that there's certain medicines that people with substance use disorders take to help them come off of opioids. And there's literature on it, like memantine and gabapentin. Then you go back and you look at our papers and you're like, well, gabapentin maybe just makes them sleepier. I just challenge everybody out there listening to look at the secondary outcomes and tertiary outcomes of those papers. Jennifer Haw from Stanford showed that, patients on gabapentin may not be getting better pain control, but they are coming off of their opioids faster afterwards. And patients on things like memantine, we can't give ketamine outpatient. We can use it inpatient, but how do we get them off after? Well, let's look for the interesting new options, things like memantine and other things that can help our patients in the long term. And I think that will give us a new appreciation of the acute pain realm and the impact it can give in the long term.
Nicholas, how about you? Has this concept of opioid-free, opioid-sparing made it over this way?
It is getting into the literature. And then with an international group from America, from Canada, from Australia, we did a narrative review and we looked for studies to demonstrate if opioid-free anesthesia was associated with a less risk of persistent postoperative opioid use. And unfortunately, at present, there is no evidence to suggest that opioid-free anesthesia is associated with a less risk of PPOU. So for me, actually, what we need to be doing is much more opioid stewardship, much more limiting the duration of the course, avoiding the modified release, sustained release opioids, avoiding the repeat prescriptions. Those are the things that we know are massive risk factors for PPOU. And in my mind, that's where we should be concentrating. Again, there's recently been a paper from Canada that showed after day surgery, regional anesthesia is especially associated with rebound pain. And it's knowing how to deal with the rebound pain is also an issue. And it's that discharge analgesia that is still required. So we need to be thinking about limiting the duration, limiting the use of unmodified and avoiding repeat prescriptions of opioids. And I think that is all part of opioid stewardship.
Yeah, I think that's a really fair point, Geeta. And just real quick, I'm going to go to you, but one of the questions we always ask is the secondary, kind of secondary outcomes of this is we do want to try and reduce the persistent use, but what about all the other things that we are avoiding if we are doing opioid sparing, like post-op delirium, and thinking about some of those other things that we try and do when we get our patients up and dreaming. They may still have to continue to use opioids, but if we can reduce the amount that we're using, maybe in a specific time frame, how that may look. So, Geeta, what about you? Do any comments on this?
I agree with Nicholas in the sense that, first of all, I don't work that much in the operating room, but certainly at Northwestern, we use opioid sparing techniques and we have a lot of protocols and ERS, et cetera. But I think that we still end up seeing patients on chronic opioids after surgery, and it becomes that either refill prescription or then going to the primary care doctor that's maybe not part of the system, who then represcribes, and then you fall off that cliff when you've been on them for a bit too long. So, I agree that that's one of our big problems with postoperative pain is where we go once the patient leaves the hospital, and who's following that patient and confirming that they have utilized all the multimodal therapy that is necessary potentially to keep their pain down and function up and to avoid chronic opioid use.
This was an excellent panel. Thank you all so much for joining, for wherever you guys are in the world, different time zones all over the place. We really do appreciate it. I know we could continue this really great conversation in the future. Thank you again so much from us here at EBPOM, and thanks everyone for listening.
TopMedTalk.
EBPOM USA is coming up July 15th. Check us out at ebpom.org. We're going to have amazing conversations with key opinion leaders from around the U.S. about everything perioperative medicine. Again, check us out at ebpom.org.